Welcome to the Washdown Podcast, episode number 52. And today is the conclusion of the two-part series with my wife, Rachel Willoughby Green. So hope you guys enjoyed episode 51. Here's the conclusion of that conversation. Episode number 52 of the Washdown Podcast with guest Rachel Willoughby Green.
Yeah. The tool that we talk about amongst ourselves because nobody talks about it publicly.
Yeah.
But I don't think that we're necessarily going to, it's one of those things, right? You look for the aftermath of stuff, but people are tired. Clinicians are tired. Clinicians are burned out. They're stressed. You know, it's because, and it doesn't let up. And then you get into the profession because you want to help people, right? And then especially when you, and depending on, the population, but across the board, all populations, everybody's struggling, I get tons of referrals and calls for all kinds of people. Even if they know, people will call and go, I know you work with first responders. I'm not a first responder, but I can't find anybody and I need help and I'm desperate. Or my child youth suicide is up. So, I mean, it's across the board a lot. And that's what we do, right? Like we respond, we help. And so as soon as, and I feel like I've talked to a lot of clinicians about this because it doesn't stop. And then nobody goes like, are you okay? Or then you try to refer to somebody and then there's no referral and there's a wait list that's too long and you have somebody who's in crisis. And we know this for a lot of veterans and first responders, a majority, like you guys don't preemptively seek help. You seek help when it's on fire.
Hey, we got this, okay?
So yeah, you got it until you don't. And so then you respond and you want to help, but I don't know, like what we talk about is different than like how raw do you want to get? Like,
so
how many glasses of wine do you, like, how many?
Yeah. Remember that intervention joke you made when you walked in the house?
Right.
That wasn't a joke.
That's what this is.
So that leads me to a question. So now you got to tell somebody, no, you don't have an appointment for them. You can't fit them in. What does that do to you? I mean,
I'm
not saying you're a piece of shit, but does that make is that how you feel?
Oh yeah, like if I'm completely honest, yeah, like it feels awful. Like if I can't and I do my best to hold space or to make referrals or get somebody in with somebody else or offer, I find time where time doesn't exist.
Yeah, you sacrifice time.
It feels awful. Yeah, and it's like, and because then you go into the space of what if? Well, what if this person does go and hurt themselves or they kill themselves or, and then I find out about that. Like I've had fears pop up where when there's a suicide and I'll run through, because if a story sounds similar, I immediately have a thought, and because I've lost people to suicide, that jumps in and goes, oh my God, was that somebody I didn't call back? Was that somebody that I didn't get on my schedule? Or, because like, especially right now, like you can't help but have those. And I think that's the reality of it right now. And for a lot of people, and obviously everybody has their own experiences. So like I have mine because I've been exposed to certain things that then I don't ever want to have happen again.
Yeah. But it's tough, but you can't.
You can't prevent what you can't predict.
But you can't help everybody either, and that's
right.
That's the hard part, and it's hard to learn even when you know it.
Yeah.
You still try, and doing triage.
Yeah.
Like that's one of the questions for one of my classes this week was triage. You got 12 people in a bunker. You have enough food for 3 months for 7 people, and you can't come out for 3 months. You gotta pick 7 to stay. How do you get rid of them?
Nelson's out.
But it is, and that's what clinicians are having to do right now is a lot of triage. Because you do have to go like, can this person, and I literally have to tell them because of the people that I see, right? Like if somebody calls me and I have to have that conversation, I'm like, if I'm looking at weeks out before I put somebody on my books, it's like, I need you to be really honest. Like, do you feel like you can wait that long or not? And for the most part, I think that anymore, I feel like people are being honest, and even first responders are like, no, I'm struggling. Or especially if it comes through like peer support or something like that, then I know like somebody's calling ahead of time going, this person really needs help. Like you need to get in.
The younger population that's calling earlier compared to the older. And I guess at this point, we're the older.
Yeah,
I know, right?
Yeah.
Yeah.
Yeah. When you walk in the station, there's plenty of times.
I reject
we're the old
that.
guys.
I reject that.
Go ahead.
just because I was the second oldest yesterday.
Yeah. we became those guys.
Aw. Yeah.
Yeah.
I mean, I do think the younger populations reach out, or I mean, there's a bit less pressure or stigma to be like, suck it up, right? Like, there's more comfort in talking about it and reaching out. But I think the peer support part, like, if you come from a department where you trust your peer support, if there's enough talk about it, because that's a big protective factor. Like having some kind of, especially when it's coming from leadership or command staff, to be able to kind of normalize some of the stuff and be addressing whether it's official debriefs or hot wash or whatever that. And the CDC, we talked about this the other day, of the things that even the CDC, when they're, came out with their like call to action against suicide awareness for first responders, of the things that do help, right? And having a clinically competent clinician a culturally clinically competent, you should be, you all should be clinically competent.
Well,
Stayed at a Holiday Inn once.
Yeah. But having a clinician who understands the populations or the culture, like having some kind of support and destigmatization from command staff or leadership, and having some sort of debriefs and peer support that people trust and that they can reach out to, whether it's across departments or whatever. And that's why, so I think when you do see that, there's enough coming out and talk about it where people are reaching out more. But obviously, like, that depends on where you're at, and that depends on the department, and, but.
Yeah, there are a lot of factors. I mean, you're talking about the culture of the department.
Mm-hmm.
So, and I would think that very few departments, I mean, probably more than I would think, but few departments are that forward thinking or have gotten to that point now. I think there are, departments that are making strides.
Mm-hmm.
Our department's one of them. We're making big strides. And
but the biggest problem you run into is money.
yeah,
How do you pay for it
yeah,
when 90+% of your budget goes to salary?
yeah. I mean, there's,
unfortunately, it's a real issue.
yeah,
What are you going to cut to pay for this? Because it's not like the budget's all willy nilly.
yeah,
It's all important stuff.
Yeah,
And,
to pay
so is
for-
this. And how much are you going to pay for it?
yeah. Well, what can you do? And I think that's where departments have to get creative on what can we do for free or for little money that's preventative.
Mm-hmm.
And I mean, that's what the peer support and good
preemptive.
training, because there are good
Yeah.
programs here locally that do a 40-hour, intensive peer support training. And like that piece is huge, right? Like, we're not talking like a couple day peer support. Like, we're talking immersion in training, and then also having a supportive team to help support that peer support, right? And then having a clinician to help support that. Because ideally, and for us, like, when you have peer support to be able to reach out to, or that's who is supporting you, so it's not always on the clinician, so that I'm not always getting the crisis calls, because there is a lot you can do for each other. And it's huge, right? Like, hearing from a peer versus hearing from a civilian clinician, like, that's a whole different ballgame, because the person's in there with you and gets it, versus, from the outside looking in. And so
we're gonna say
peer
things-
support doesn't cost outside of the training, right? And so that piece, having a good EAP where you're vetting clinicians, that people aren't just going to, you can have all the good intentions, but there's, people have a lot of negative experiences with clinicians out there when they don't understand the population.
Yep.
Tell us about that, Chris.
Thing is, I'm not the only one.
Right.
That cultural competency is it's immeasurable. Because if you don't understand, you're just going to piss people off.
Mm-hmm.
I mean, I told the guy I talked to go fuck himself. And we were on session 3 out of 5, and I was like, I'm not calling you back. We're done. I'll do it on my own. That's because that's how it felt. I'm like, I still feel alone. I mean, I'm dealing with burnout and how I can go back to giving a shit. And it was awful. I'll be honest, the guys at the station, that's what worked for me. You know, friends and family.
Right.
That's what worked. But, you know, not everybody has the same path they're going to take, but
Well, you know, and we've talked about it, and I've talked about it with multiple lots of people.
mm-hmm.
You know, there's no one size fits all.
No,
And know what's going to work for you may not work for me, may work for James, may not. Who knows? But, and again, depending on where you've caught yourself at on that road, you may not necessarily need therapy. Maybe it is just peer support, or maybe it's 1 or 2 sessions with a culturally competent clinician.
Mm-hmm.
You know, who's to say? But ultimately, that comes down to it's individual.
But
Well,
I
and
think
it can take multiple things. Yeah. It's
Yeah.
not just there. Like, you got to
Well,
turn
yeah.
over a lot of stones
Yeah,
sometimes to
absolutely.
treat trauma.
and I think getting the clinicians culturally competent is one, going to talk to them before, you know, like you and I going to talk to them before they see any patient, anybody else. And then if they're not culturally competent, but they want to be and they show that desire to be,
Mm-hmm.
bring them in. Like, okay, these are the guys, these are the girls. Talk to them, not as a clinician, but as a friend. Get to know them.
Mm-hmm.
Now understand our life and what we do and how we see things. And you kind of train them on it. And, you know, they've got the clinical side, but now we'll give you some experience with us.
Mm-hmm.
And then that's how we build our support group, essentially.
Yeah.
It's going to take time.
Right.
It ain't going to happen overnight
Yeah.
because we're some weird people.
Yeah. Yeah.
Put
We're
that
very,
nicely.
yeah, very closed to outsiders,
Mm-hmm.
and you have to earn your way in.
Yep,
It's like a gang.
pretty much.
You do.
why
Yeah.
you get
So
the
it's a
tattoo.
big deal to
Jump in, jump out. So, but no, I mean, that's just the fact of the matter. And I would assume police officers and military are pretty similar to that, where you know, you're not one of us, you don't understand.
Yeah.
So
And you're extremely leery of them because you're not one of us.
yeah.
Mm-hmm.
Well,
One
and there's
of us. One of us.
especially if you're still
I was
working,
3
right?
seconds away from saying it.
yeah,
So for a veteran, it might look a little different versus somebody who's, you know, active duty or reservist or whatever, because there's a chance that, well, this stuff could come out or where there's a record. And then for first responders, there's always that fear about,
how is this
you know,
going
what
to
do you
affect my job? How is this
Right,
going to affect my
right.
reputation?
Mm-hmm.
If the guys at the station know that I'm here laying on a couch talking to a shrink, man.
yeah. So, and so for clinicians to even know that piece, right? Like my dream is to be able to come together with more clinicians where it's an office that is just that, like just the populations we serve, you know, that's who's coming in the door. You know, but like one of the things, like that's not my setting right now. Like I'm in a setting and so there's a lot of civilians coming in. So majority of my clients, and I just I schedule myself to where people can wait out in their truck or whatever, and they text me, and so I can go and get them, and they come right in. So they're not sitting in the waiting room, you know, potentially either running into somebody or somebody seeing them, or, you know, somebody they arrested or ran a call on or whatever. So even little things like that of just understanding that, you know, your first responder may not want to come and just sit in the lobby because you don't know who else is going to walk through that door. So being able to just acknowledge that and create that kind of respect and safety that, like, just text me, I'll come and get you and you can come in, you know?
I've definitely seen more openness, at least in our department, with it. Talking to guys like, oh yeah, I'm going to see so and so.
Yeah.
Been doing it for this many months.
Yeah.
You know, and kind of what happened. But that also depends on how well they know you.
Yeah.
Like if they can trust you or not.
Yeah. Well, a lot of I have found personally, a lot of people are still pretty shy to talk about stuff,
Mm-hmm.
and depending on where you work or what shift you're on or whatever, I mean, there are still those old thoughts, and
It's
you know,
looking at it as a whole, I've definitely seen a shift.
yeah,
It's slow and it's a little bit, but it's been getting
It's
larger.
It's
gradually.
leaning in the right direction.
Yeah,
It is. So
and I've seen some other things that have been good. So
see all kinds of
It
good
is
things.
like
I'm just gonna
there's
leave it like
there's an
that.
openness. Yeah, it is different, and it's going to look different from fire service to law enforcement, and because just different risks and culture, and yeah. But that is why we need to continue to talk about it, and why it needs to come from leadership and command too, and then from people who other people respect and
but
trust.
I think the only way to see the change and to make the change work is from the bottom up. Because
Say more.
if it comes from command or the management or however you want to phrase it, people are going to see it as, oh, I'm getting forced to do this. But if it's coming from the bottom of the ranks and working its way up, it's, oh, you're going through this. We want to help. So you're seeing it as they care more and they care about you. You're not just a warm body in a seat, which with a lot of companies or even certain departments around, because of staffing issues, that's what they're looking for is a warm body in the seat. This is what it feels like when you're the one doing the work.
Yeah. Well, I think it has to go both directions. I think you have to have a command staff that is willing and able to do what needs to be done, but then also the membership has to step up
Yeah.
and start making that shift. So I don't think it's one way or the other, because command staff can't mandate it, because then
No.
the guys are.
But that's how people are going to
That's how
view
people
it.
will feel.
So when it starts on the bottom and then command sees that, they're like, all right, we recognize the need. We see it. We want to help. So now they're not forcing, it's like, reaching out and giving that hand up. It's just like a basketball. You go down, your teammate comes over and puts his hand out. It's easier to get up as opposed to when they come over and grab your jersey and try to pull you up. What happens?
Yeah,
It's
you're both on the ground.
Yeah. That's where I'm getting with it.
Yeah.
Well, and I think my perspective too is not just how leadership, and this is coming from me as a clinician and, just the exposure to it. It's not just about like what policies or something that command staff is putting in place, but how they're also showing up in it. And so, and even just owning their own stuff and acknowledging what some of their experiences have been, because there's a huge piece to normalize. Like, I've been there too, or I've struggled with that too, or like, this is normal. Like, these are normal responses to abnormal situations, and I think that is a huge piece when people are like, I'm not crazy. Somebody else has felt like this, because even that like numbing, and we talked about this the other day, because of like just kind of starting to feel like numb or not being aware of, because what do clinicians do, right? Like, you come in and we want to go like, what's going on inside you? And for a lot of military, for a lot of first responders, it's like, I don't know what the F's going on in here, right? Like, I can't, or you start to just feel like dead to it. Or if you start to look within it, it's going to feel like a flood, and you're not going to be able to shut it down.
And, that reminds me of the other we were talking about to go along with that is, the way that we're trained and the way that we think or whatever is we have to shut all that stuff down to do our job. Whenever we're on the scene of whatever call, personal feelings, emotions, all that stuff goes out the window, because we have a task, we're oriented and do the task. And then that's it. We don't bring it back out and deal with it and all that stuff, because we're
Right.
never taught that part of it.
Right.
So
how to turn it back
yeah.
on when you get home.
Yeah, so we get really good at turning it off. And then whenever we get home, something's uncomfortable, whatever, well, this works at work. I'm going to start doing it here. So then you start doing that. So, and then again, steps, progressions.
Right, because in a sense, it's
It all
adaptive.
comes out
Yep.
over spaghetti.
Right. Right. When it comes out as the thing, it's not that at
Yeah,
all,
yeah,
right?
yeah.
But it is like, so to normalize it, like, it's adaptive in a way too, right? Like, it doesn't matter if you're tired, if you're hungry, if you're stressed, if you have an emotional reaction to something, right? Because you have to do the job. Like, the mission is bigger than that. Like, handling your job is bigger than what it is that you're individually experiencing, right? In that moment. And so there's a piece of it that is adaptive, and then there's a part that's learned, right? Because you learn how to like compartmentalize it, but you're not taught like really
Really need
compartmentalizing
to-
on how to get it back out, like
Yeah.
how to address it or how
We
to
need to
process
change
it.
we need to come up with a term for that because it's not compartmentalization. It's like,
Right. It's not compartmentalization how
Yeah.
compartmentalization should be used.
exactly.
Yeah.
It's
It's more about
like-
avoidance or shoving it under the rug or putting it in a black hole that you're never going to open up again, which is not how it works.
Yeah.
Because avoidance just leads to, and we know that, like avoidance leads to more PTSD symptoms or leads to more PTS symptoms, which can lead to,
PTSD.
yeah. So, but I think, and then that piece where you guys can help spouses is having some kind of awareness or some kind of agreement of how you talk about that stuff. Because the way that I describe it, and like, I don't know if you and I talked about it, like Mad Libs, like filling in the blank, right? Because if you come home in a certain state or you're quiet because there's my gong again. I don't learn clearly.
All right, have a good night. We're done.
Like,
Come back for part 2 when we tie our hands to the chair.
right. It's getting weird real quick. Is to be able to say something, right? Like, so for example, you could, after, I don't know how long that was, you ran
It was not very long.
then once you were back on the job after everything, after getting out of the hospital in Valor and all that. So, and then you run a call that brings all that stuff back up, right? Like you run a suicide that just reminds you of everything that could have potentially, and then you're exposed to the family and all that, right? And like, you know how different that looks when the family is present and you're dealing with their emotions and not just the person, you know, the patient. And so it was 3 days. Like I knew something was off, right? But think about it like Mad Libs of like, here's pieces of your story and then here's all these blanks. And then because of my own experiences, the lens that I'm going to look through, I'm going to fill in those blanks with my own information because you're not giving me any, which then changes the narrative, right? It changes the story by the way that you fill in those blanks. And so once you were able, and I know at that point I was able to like continue to just be like, no, really, like something's off. What is going on with you? Because I'm telling myself something else. And then you were able to acknowledge that and decrease it, right? Like be able to own what you were feeling, which you were trying to protect me, which is what a lot of partners do, right? It's like you come home, you want to protect your spouse from difficult things. But in that moment, you needed to own it. You didn't have to give me details of it, right? But enough to acknowledge what was going on. And then both of our stress levels came down, right? Because mine knew because I could fill in the blanks and know what was really going on. Yours because you could acknowledge the emotion of what you were experiencing and just go like, okay, I know what's going on. I can label it and then move on through it. And that's a big piece, I think, for partners to be able to come, even if it's like, I had a bad night or I didn't sleep or I ran a bad call. And you don't have to give details, and spouses need to respect that and not push it and not ask for details or not push, to know that you've got to have time to decompress, but saying something so that your spouse is not filling in the blanks. Because especially for so many spouses, like it goes to, he's talking to somebody else or he's leaving or he's drinking or, you know, like we fill in the blanks with all kinds of different stuff, and that changes the story. So, yeah.
Yep.
You got to give your spouses something.
Yeah. It's about communication. I know where your mind went right there.
Oh, Lord.
that grin.
I was debating. I'm like, should I? No, yes, no, yes, no, 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 yes, no, maybe. Okay, I won't.
Yeah. Mr. Moran, you've been
Stuff that comes up.
unusually quiet for like the past 45 minutes. Yeah. Did you?
Oh, turn your mic back on.
Well, I get tired of getting yelled at for breathing in it.
Well, you're not supposed to put it in your mouth.
It's getting creepy.
Not a cupcake.
Well, and this was, I don't know if you remember last time we had Rachel on. Outside of just like kind of talking shit on you like we all had fun doing.
Uh-huh.
I really kind of sat back and just listened because this is the one story that I wasn't there for. Like you
yeah.
two were and Chris was. And I wasn't. And I find myself, I don't really have a lot of questions. Like I can gather, well, like you and I know what happened. We've had talks about it, but it's actually just interesting hearing not only her perspective. I don't really care about you. Not only her perspective,
I appreciate that.
but Chris's perspective as well. Because this wasn't just a Jeremy event. It was just as traumatic for Chris as it was for Rachel as it was for you.
Yeah, and that's the thing that's often overlooked is of how many people a suicide or a suicide attempt actually affect. It's not just me or her. You know, it affected Chris. It affected Jane by association, you know.
Right.
And
all of my family.
Yeah,
all
all
of your
of her-
nieces and nephews. All of your family.
Yeah. So, I mean, you're getting into the triple digits really fast.
You know, and then if you can take it a step further when you look at work. It
Yeah.
affected your crew, the
Yeah.
entire shift and battalion, and even
Yeah.
others, because now we got to fill in.
Yeah.
So it just adds.
Yeah.
I mean, it's far-reaching.
Yeah.
And nobody really.
Yeah, it's the thing that people don't think about.
Yeah.
Well, and what's interesting is like you have the opportunity to think about it because you are still here.
Yeah.
Right.
Like,
Right, because this entire story, right, even like me and my life and my work would look profoundly different right now, and I may not be doing what I'm doing at all, or I may still be because of it, but it looks very different because he's still alive, which then gives us the opportunity to do this and to talk about it more.
you know, it's like, and it's a terrible analogy, but hear me out. It's like,
I love it when people preface stuff like that.
This is gonna be
Well, I mean,
bad.
it's like at the just hear me out, damn it. It's like at the end of Twister, right? When they actually get to throw the shit up in the tornado and they see it, like,
You mean Dorothy 5?
yeah, but like
Say it
essentially,
right.
we've kind of got an inside man. We've got somebody that's been down there to where most people don't return and has returned. So it's the
We're getting a lot more information than
Yeah.
anybody else has that's sitting on the outside.
Right.
Right.
yeah, so like Twister.
I like how you
the
reach
little
for that
things
one.
that go up into the tornado,
Yeah.
and then they get all the data from it.
That's Dorothy 5. Because the first 4 failed.
Oh,
That's the
okay,
movie we
sorry,
watch a
I
lot
got it
in
now.
my house. My wife
I forgot it was
loves-
called Dorothy. I thought you were
My
trying
wife
to like.
loves that movie. I do too. But
I love Twister.
I gotta
I
go,
wanted to be
Julia.
a
We
store
got
chaser
cows.
so bad because of that.
Another cow. I think
That's
it
the
was
same cow.
Patricia, I gotta let you go. We got cows.
Oh, that's great.
Oh yeah, she was a
The
therapist.
extreme.
Of all the movie references I thought might pop up on this podcast, that's not one of them.
That's a great movie. It's a
But do you
classic.
guys get my point, though?
Little Shania Twain there in the
Yeah.
background?
Yes.
What's interesting is that we also have to balance that fine line. And Rachel, this is even more kind of like interesting for you, is you have to balance that fine line between like wife Rachel and
Yeah.
support Jeremy, and then clinician Rachel. What can I get out of him to learn from that road he's been down in?
Oh
and back?
yeah. Yeah, because I do, and we've talked about that. Like, I have to be really careful that I'm not stepping into just like seeking data or voyeurism. I'm just curious about what's going on in your head, and I have to be really respectful about that.
Can you repeat that one more time? I didn't get it written down.
Yeah. And so what happened?
Right.
How does that
Because
make-
then that's
no,
me,
she
right?
Says, how does
I-
that make you feel a lot? I know it. I know
Yeah,
that
no.
question is like, Jeremy's going to go, you're going to come home and there's going to be a piece of wood that he's burned in there. How does that make you feel? We're going to hang it over the couch by the horse picture.
Because and that's me, right? Like, I did that. I look back at my journals because it helped me a lot to understand more like acute trauma responses too. Because like I tracked what was going on for me. Like, I tracked how many days it was that I wasn't eating, how many days it was that I was like maybe a little more prone to want to drink or to drink to go to sleep, or how long it took me to then get a full night's sleep. You know, like, I tracked all of that so that I could kind of normalize, because we'd all talk about like this 2-week mark. I'm like, okay, it was legitimately in this 2-week mark that I started to regulate. And then I had that delayed response. So it was helpful for me. And that's kind of how I work, that I'm going to explore what's going on. I'm going to seek information from it so that I can see just from real life experience how it's helpful. And then why we talk about it so much. But I do have to be careful that I don't seek more information than you want to give, because I'm just pulling data. But it's
Just a clinical trial. That's it.
yeah. That's why we're still married.
Hey, you know what though?
That's one expensive trial. I don't know how you put up with it.
Yeah.
Exhausting.
But you know what though? I'm fine with that because it's no different than the reason that this podcast got started. It's because if I can give you one piece of information, just one, that helps you with one of your clients
Yeah.
or somebody else,
Yeah.
in the same way that if we can say one thing on this podcast, just one, that will keep someone from going down that same road,
Yeah.
that's worth it.
Right. Yeah. Absolutely. Because this is a thing that we don't very often get to talk to somebody who survived an attempt, right? Like you have those people in there, like and people who have actually done interviews and stuff about, what was going on before. And then like that moment of realization of death, and then kind of a moment of regret or whatever, but it's not very often that you get that. And then a lot of people don't, like for you, and I think it helps people to know, like because we wonder what if, like what could I have done in that moment, or what could I have done differently, or what could I have seen or not seen? Because if that hadn't have been interrupted, that's the space I would be sitting in, right? Of wondering, like, would you have regretted it, or could I have done something, or could I have stopped you, or whatever? I'd be living in that. And I'm really, really grateful that I don't have to live in that space. But I think even for me, it was helpful to know, because I really did need to understand, like, was there something you were thinking about? And I wanted to know that for the sake of other people, or to help other people. And so, because so many people talk about it at that moment of not, like, I couldn't see beyond that, right? And so for you, there was that experience of it. And that's why suicide is so painful too, because there's answers like we're never going to get. Like that person dies with a whole lot of unanswered questions for the survivors of it. And so I'm really grateful that I don't have to have those. And that's probably why we do talk about it, because if there's something in there that could help someone else, because we don't get to know, right? Like people are trying to figure out why it is, and people are trying to do research to even understand, like, is there something we can identify in the brain that is happening in that moment that we could do differently? Because like it's a horrible death to have to live with. And we don't entirely know, right? But we do know that it's clearly a desire, maybe not necessarily for physical death, but to get away from something.
Yeah. Well, and like we
So
talked
painful.
about, you would think with the way that our brains are kind of wired for self-preservation.
Mm-hmm.
That
Right.
it
It's really
wouldn't-
counterintuitive.
It's super counterintuitive. Like, you wouldn't think it would be an option. Like, it wouldn't be a thing for
Right.
humans to take their own life. You know?
Mm-hmm.
Especially with like a spur of the moment thing.
But that's where I would love to really dig into what data is available and look at the different causes, right? So we have the I don't like where my life is going cause. We have the I don't see a purpose cause. Then we have the I don't want to be a burden cause. Like there's so many different causes. So I would be interested to see somebody that maybe got a second cancer diagnosis, right? They beat it once, got it again. I'm not putting my family through this again. Kills himself.
Mm-hmm.
That may be a completely different reason than why somebody who is unhappy with their life may, right? Like it's
Right.
so.
Well, I think there's
When you talk about the counterintuitive, like it's almost, it sounds really weird, and hear me out, but it almost seems like more thoughtful of others, depending on the scenario. Not encouraging it, not saying it's right.
Right, which is the thought
Well,
that people have, like I'm somehow
that's-
sparing other people, but
Yeah.
that's what we have to, that's one of the things that we have to talk about in it and destigmatize, because like Dr. Springer talks about it in Warrior as well. So even if you talk about a culture, and so, she specializes in working with military and now works on the side of like suicide survivors, so families and stuff of those who have died by suicide. But their job is to eliminate threat, right? And so if at some point, like in their minds, that they become the thing that's threatening, that they're the thing to eliminate, that then somehow it's still doing the same job, that they're protecting other people by eliminating themselves as the threat, right?
Which is just a big fucking lie that the
Right, because
brain
everybody would
tells.
say no. Like,
But
because
that-
I would
Yeah.
have said to you, if you would have died that day, I would have said, what I live with on knowing about you and infidelity is nothing compared to your death and your death by suicide, right? And so, and that's what every survivor, suicide survivor, lost survivor, like those who are left behind, right, would say to that person, like, no, I would rather you be alive.
Did you ever hear that show, Right to Die? So I saw part of it. It was on HBO, I think. So it was this guy went over to Switzerland for assisted suicide. He had Lou Gehrig's disease. And basically they gave you, if it's the same show that I remember watching, they give you the stuff to drink. And it takes like 30, 45 minutes to work.
Mm-hmm.
But once you drink it, that's it. And they were interviewing about everything, and basically his reasoning was he's at that stage of Lou Gehrig's disease where you're
shutting down.
yeah, and I don't mean to say you're a burden because you're not, but he feels like he's a burden to his family. They have to do everything for him,
Mm-hmm.
and he's done, and he doesn't want to wait and suffer. So I think, being able to go to a country like that and talk to people who have made that decision, I think that would give us some insight on the traumatic part too. Not all of it. I mean, there's still so many pieces, but at
There
least
are.
we could get a foot in the door maybe to an understanding of why.
And that's why it's interesting. Like, of course, the family will say, "Oh, we'd rather have my loved one here. We'd rather have in a situation like that. We'd rather them be here. We enjoy them. We want them here." Is that out of selfishness? Is it? You know what I mean? Like, and we're talking about one specific example here, but like, is that a selfish thing? Do we have to take a look at the bigger picture of I'm not getting better? It's going to be more of a burden on you. I don't want to be in pain. You don't want the ball and chain of taking care of me. There is a scenario. There is a scenario to fix this here.
Here's what I'm going to say
I didn't
about
mean to
that.
start a debate on
No, I think
suicide.
it's a whole different
No.
right. Like, we just got into a whole different realm.
That's a whole different ball game. But I think in that situation, I think each situation is different, and it's such a personal choice as far as when you're talking about a terminal disease, especially like that. My best friend back in Louisiana, his mother passed from ALS. It's a terrible disease.
Take my ass out to the pasture and shoot me,
Yeah.
please.
So, but when you start talking about, so you have suicide as a whole, right?
Mhm.
And then you start adding all of these things onto it. Like, well, this person had a terminal disease and they chose assisted suicide, or, this person was depressed and then they killed themselves. Yes, they're both suicide, but they're very different things. And I don't
You're
even
also-
know how you would.
You know what
I
brought this?
think you got to because of
You have to
treatment too,
separate
and
it.
this is why, because what we're talking about when you want to talk about suicide prevention and awareness, and like for you guys too, right? Like for these populations and for youth, it's understanding that what they're talking about and what is leading to suicide are things that are treatable and things that can be addressed, right? Like all of the stuff that you went through, like that stuff could be addressed and treated, right? Like you look
Yeah.
at how quickly you were able to. That's a lifelong process, but I think that
But-
'cause I
but
wanna
in that
separate
moment,
those
it
out.
wasn't, and that's where I'm seeing
Right,
a
which
connection.
is-
For a brief moment, it's not treatable. This is the only way out.
And see,
in
that's-
his mind.
That's what.
Yeah.
That's
Yeah.
why I
Like
brought
that-
this whole point up is
to foot
because
the
he
door.
talked about how the thought that would be suicide would be a last option because of the way we're designed is for self-preservation.
Yeah.
Yeah.
And that got me thinking. Well, like, are we?
Well, again, though, you're adding a very specific stipulation onto it. You kind of have to take the whole self-preservation thing out of it, because you're talking about a disease that is 100% fatal. There is no cure. It's completely progressive, and you will be incapacitated and essentially unable to communicate or do anything on your own for quite a long time before you pass. And, you know, that's horrifying for people.
I think how I'm looking at this as a progressive, like look at it as like a ladder, right? Like at the top we have that suicide because of progressive disease. We don't want to put burdens on people. But then right down here we still have that, the next step, which we could probably identify as treatable, would be that suicide because of loss of purpose, loss of future. Is, you know, like, I think that's more difficult to treat than a infidelity, I am not happy with my life, I have an addiction problem, something along those lines. When you have, say you take especially with first responders, you take a first responder out of their career, say they get a DUI, we'll say that, which luckily, say they get a DUI, they lose their EMT license or something like that, their career fires them, some sort of action, something that, loss of a limb, where they can no longer do their career, then you have suffered a great loss of purpose, especially when you've identified yourself in your career. How do you treat that? How do you force someone to find a different perspective, to find the same sort of usefulness that they had before?
Well, you can't.
Sorry, go ahead.
I was going to say you can't force anybody, especially with something like that. What you can do, at least from my perspective, you can show them that they can still be valuable and give them options. You know, and that's the importance, I think, in wanting to do something, you know, and being committed to doing it, to getting better, to going through the process, knowing that it's going to be hard, whatever, you're still going to do it. You're not giving up. Even though, yes, I've lost my sense of purpose for this, it sucks, I can't do that anymore. Let me figure out what I can do. And I think that comes down to perspective and mindset. Now, how you get that perspective and mindset, you know, that varies by individual. Some people do it all on their own, and some people need to go see a clinician.
My concern is, how do you get it before you would possibly commit suicide?
Right. And well, and that's a lot of the work of the preventative work, right? And because you get, like, the field that you're in is reactionary, right? Like something bad happens and you guys react to it. It's not necessarily out there preventing all of those accidents, right? And preventing that stuff. And so, which then kind of becomes a part of the culture. But I think that's why we have to talk about the prevention piece and, like, understanding that, like, don't go into this field, this being the end all be all, and that this is who you have to be. And if you're not this, then you're nothing, right? And acknowledging that that can happen. And so I think even just normalizing that and going, you got to set up for having life outside of it. Don't eat, live and breathe it. Because the potential loss, because that's the reality of it, right? Like, you could get hurt, or like anything could happen. It could be the different scenarios. Like, you could have all kinds of different scenarios that pull you out of the job. And so I think that that's a piece of it, of just recognizing early on and getting at people early, going into the career, right? Like, how do we continue to set up better, healthy mindsets and support systems and life outside of these careers? And because regardless, like, there's something wrong, right? Like, when you guys are in fields that are high risk and more people, there's been more deaths by suicide than line of duty deaths, that's a problem. When we have so many kids who are killing themselves, and by even more extreme means like firearms and stuff, where that wasn't like the top thing for children. And so that we're getting that, like, that's a problem. Something's wrong, right? And so, but it is starting to look at, like, we've got to go back and go, how can we set people up better? How can we prevent more?
I'm curious if you remember the data or would have the data. When we talk about our veteran suicides, do we see a larger percentage of suicides in the base of the injured, or the physically injured, or physically not injured?
So I don't know if I know that it's split up. So, because I think that, because it's complex, right? Because for somebody, if there's a physical injury, then that physical injury also, like, there could be PTSD because of that, right? Or like associated with the same incident that caused it. Or then when we're talking about specific injuries that also cause brain injuries and stuff like that. So I think it's, you know, like we talk more about PTSD in regards to it. And because we know that, right? Like we know that that's going to increase risk and trauma is going to increase risk. But I don't know about data that necessarily separates because they can be so
Intertwined.
Yeah.
Yeah.
There's
and-
not usually one with necessarily without the other, especially if there's a
Well, 'cause-
physical injury from.
Because my question is, I've noticed a lot, especially those that loss of limbs, right? We had lots of loss of limbs in this last conflict due to IEDs and things like that. And I've noticed, like, when they come back, they get lots of treatment, lots of rehab, physical and mental. A lot of them are placed in jobs. They have lots of opportunities because of the injury they suffered. Whereas, like, if you didn't, you're like,
That's what you're talking about.
yeah.
Yeah.
If you didn't, you come back and you're like, good luck.
Because the invisible, right? That's
Yeah.
why we talk about the invisible
Get on
wounds
out of here.
war.
See you later.
Yeah.
Yeah.
And
Oh yeah.
yeah, it's
Yeah.
Well-
And there's that comparison, and I think you guys do. I hear it all the time, both from first responders and from veterans, right? But like, I came back better. Like, if you take the whole of like my friends who both served or my unit or whatever, and like I came back the healthier of the rest. Like, I'm effed up, but I'm less effed up, right? And so then there's that. You guys minimize, right? Like, we know this. Like, minimization is huge. Right?
What?
Everything's fine. And so there is that piece, right? Like, well, I don't have, I have all my limbs. I just have this. But so then they minimize the invisible wounds, right? Like because PTSD doesn't necessarily show up on the outside. And so, and the same thing happens with you guys, right? And I'll have people come in, well, I've never been in combat. I shouldn't feel like this. Well, I haven't been in a shooting. I shouldn't feel like this. Like, regardless. And I think that's a piece of it, but that's also part of the problem of the expectations around it and shame and what it should look like and minimizing things or suffering in silence. Because then that stuff's not getting addressed and treated.
The minimizing is interesting to me. My ex-wife used to tell me I was doing that all the time, and it drove me crazy. So it's almost like a buzzword for me, almost. Because
Did that trigger you?
yeah. Well, because like we make it's, again, part of our career is to minimize, right? If we had the same reaction for a cardiac arrest as we did for the person with the toe pain, you would say we would not be fit for duty, right? They cannot be met the same way. And yeah, that's going to apply to a lot of things. Like, this person is missing a limb and partially blind, and I had a broken leg out of the deal, but it's healed. They are not the same. The reactions cannot be the same. They should not be the same.
Sure.
And so, yeah, of course we're going to minimize because we recognize that need. But I think what's difficult for us is, like, just because we may minimize it doesn't mean we get more or less treatment. It's just a different style of treatment.
Yeah. So are you talking about, because I'm talking about minimizing your own stuff.
Again, that's the same thing.
Yeah.
Like,
Yeah.
So
The problem, sorry, I keep interrupting you. Go ahead.
no, you're good. You are the clinician, so you know more than me.
Not necessarily.
I was just going to say, it's funny that you bring that up because earlier today I was watching a podcast with Mike Tyson and Bill Burr. Yes, it was hilarious. Hot boxing. Mike Tyson has his own little podcast with Jeremy Piven.
the podcast.
Yeah. And so they were talking about, and Mike Tyson asked Bill Burr, he said, I've heard that all of you comedians are fucked up. You had fucked up childhoods and this and that. And Bill Burr told him, look, my upbringing compared to your upbringing, he goes, I'm not going to sit here and complain about that. He goes, it was nothing. And Jeremy Piven made the point, and then Mike Tyson chimed in as well. And they're like, no, man, trauma's trauma, and you can't compare that. Yes, what Tyson went through as a kid, terrible. But what Bill Burr went through as a kid, equally as terrible in its own way for the way that it affected him. So whenever we sit here and try to qualify, well, yes, I've ran all these calls and they're fucked up and this and that, but I wasn't in combat and didn't see my buddy get shot. That doesn't matter. You can't compare.
You know, there is that slippery slope. I'm playing devil's advocate here.
Yeah.
We're going to play that slippery slope of participation trophy mindset then.
Yes. You're not wrong. If you want to fly that flag,
I'm not saying like nothing. I'm not trying to disregard what we're talking, but there is that slippery slope of like,
yeah.
Well, my feelings matter. To what extent?
You can have this one.
No, because I hear you. Because we also don't want to generalize everything and like or minimize or maximize everything, right? Because it's not necessarily all like somebody. It's still experienced differently. Like I think part of what you're saying is that you don't get to choose, and you don't get to choose how your nervous system responds to it. Right. And so that one significantly is a piece. Like we don't get the choice over how my nervous system is going to respond to stuff. And part of that can be from previous experiences too. But I think that it doesn't. So it's like taking individually. And I think that's the bigger thing. Like it doesn't have to be a conversation necessarily of comparison. But if you want to get complex about it, like it's going to look different with FMLA or disability stuff or whatever, right? Like I think that's where stuff gets a little bit more, or the debate about stuff gets a little bit more complex. But I mean, I understand what both of you are saying.
You talk about like when you're looking at appointments, there comes to a point, especially right now with the crisis that we're having, there has to come some sort of triage, right?
Sure.
In our medical field, triaging is easy. Like you have a broken toe, you're not going to die. You're shot in the chest, you are going to die, and we can physically look at it and say you're fine, you're not. Whereas 2 voicemails you may have on your answering machine, that's all you have to triage from. And you know, then now it's up to you to say this person needs to get in here quickly, this person doesn't, but the end result for them is the same thing, like which could be potential suicide. You are not going to die from your broken toe. You are not going to. It's that simple. You could die from this crisis that you're going through because it may be the worst you've ever had, and suicide may be the only outcome you know of. And all I have to do is this voicemail to make that determination. It's scary as fuck to me.
Yeah. Well, and I typically have more like somebody screening more in some way, right? Like, so for some clinicians, they have somebody answering the phone that's maybe screening, or if they're questioning, then, you know, I mean, I have a conversation with a lot of people where I don't necessarily determine it based on a, you know, a voicemail or something. But I think that also becomes a part of the piece where it's like, we have to also acknowledge that none of us are superheroes and have all the power to figure it all out and to know the right answer and to be able to have the crystal ball and know what that person's outcome is going to be. Right. But for us clinicians, obviously, like, and there's a screening process, and there would be things that we would ask, and depending on the population too, of where you kind of know where somebody's maybe a little bit more risk than another. And then you do your best for referrals, right? Because I like try to do we all do the best we can on giving people resources and referrals, and, you know, somebody that they can call or getting them connected where they know they can get into another place. But it's hard because none of us, and that's the same struggle I think for first responders, is you can't always control the outcome or know what the outcome is going to be. Like, you do your best with what you know in the moment.
Well, into like it's pretty objective for us, right? Like I can look at a EKG and say, you are having a heart attack.
Yeah.
You are shot. You are, I hope you're answering these questions truthfully.
Right.
Like it.
Right.
So. Sorry, I just had to throw a monkey wrench in this whole conversation.
Right. Well, no, it's true. And then you go by your best clinical intuition, and yeah. But it's not cut and dry, obviously. It's not a hard science working with people. So.
No.
Yeah.
Yep.
It's not. All right.
Can we talk about how you just totally bailed on my question? No, you're like, you can answer this.
I get it. It's a difficult question to answer because it's like you don't want to minimize and invalidate what someone
Yeah.
experiences. But yes, are there sometimes qualitative differences between experiences? Yeah. And then the hard part is like, could I look at, one of the examples that get brought up all the time is for, the kid that doesn't have anybody to sit with at the lunch table, right? And everybody's like, well, that's trauma. And I feel like I probably shouldn't even bring this up. Everybody's perspective is going to be different about that, right? Like somebody's going to say like, that's a big T trauma or a little T trauma or whatever, or I'm traumatized because of that. But I think regardless, like typically, and so it's not looking at it for an excuse. And I think that that's a big thing for me. Like, don't look at it as a reason to be away or an excuse to be away. Like there's stuff that changes, but my work is focused on first responders and military, right? So like my focus is going to be on experiences and trauma and chronic stress associated with those populations and those experiences. But nonetheless, am I going to minimize anybody's experience that is difficult for them when they come to my office? No, because like that's the way that they're experiencing it. So I think across the board, we don't necessarily want to minimize, but I understand what you're saying. Like there's a difference, between experiences, because then there just is. We don't choose how we respond to it, because sometimes that's just a reaction, and sometimes it's what we've learned in our relationships and our support system and how our brain works because of development or neglect or whatever. Like it can be complex, but
I don't think it's as cut and dried of an answer, as you were hoping for.
Or that Jeremy can give.
Yeah.
I really wasn't
Take
looking
somebody
for
smarter.
a cut or dry answer. I really just wanted the conversation out of it. So I saw a video the other day, and it was of like this college. It was on this college campus, and it was like some caucus thing they were doing, and it was a political based event, and they were all very far right, and they were all really focused on like sensory awareness for the meeting. So nobody clapped. They did this.
Oh, I know what you're talking about. Those were all far left people.
Or far left, yeah, not far right. Sorry, far left. And they
Yeah.
were like, yelling at each other, like, "Stop the background noise! I'm completely overloaded with my sensory." And I'm just like, "What?"
Yeah, but they kept doing point of order.
Yeah, they're like, "Point of order. We can't have that." Like, I was literally just like, "Oh my god,
Yeah, you're not gonna get anything done.
these."
'Cause
Like,
everything triggered
yeah.
someone.
And so my point being,
right.
like,
That's like our culture now.
This is why everybody
So-
jokes like I'm triggered right now.
so
Right.
okay, but
Yeah.
here's my point. Like,
Yeah.
I'm diving real deep in here, but just stay with me, right? For a productive society, right? That seems counterintuitive.
It is. There has to be.
There's no resiliency.
Yeah.
Go watch Jordan Peterson.
Jordan Peterson.
Peterson.
Yeah. There has to be a level of resilience that people need to have.
And so my question for you, Rachel, is how do you teach that? How do you teach somebody to be tough? How do you tell them that their reaction may not be appropriate? Because sometimes it just isn't. Just isn't.
Send everybody through buds
You know what I mean? Like,
or the Q course.
and maybe that's why with first responders and military, maybe it's easy
You
because
could pass on
we
the well, it's real easy.
for the most part,
Pass.
like, well, for the most
I know this is what happens. It's that pressure, like at a debrief, like y'all have the right, like the choice to pass, but everybody gets the social pressure of like, but I have to
Oh,
answer.
you better answer this shit.
but
The
no, like,
thing is, there's not a good answer to that question because you have to teach everybody differently
Well-
how to respond to the same thing.
So there is a good book out, The Growth Mindset. So you could read that book. So I'll just say that.
Grant, go read the
the Growth
I'm just
Mindset.
gonna watch the movie.
Grit, like there's a book, Grit, like that's a,
True
so
Grit?
I think that, no, like,
No, just grit.
because that is a concept that people are studying now, right? Like, how do we study grit? How do we study growth mindset? So, like, even for a young child, the child that hits something difficult and wants to work through it versus the kid that says, I can't do it, I can't do it, I can't do it, right? And so, like, people are studying that. But I think it's more complex, right? Like, if you're talking about kids, it's going to look different than talking about an adult. But sure, there are going to be times like if somebody's in my office and I'm hearing too much like and I don't want this to sound like disrespectful or minimizing, if I'm hearing too much of that like victim mindset and I'm sitting in that space of just victim mindset, I'm sitting in my poopy diaper and I'm not getting out of my poopy diaper, right? Like I'm going to challenge that, right? Because I tell people all the time, like, don't sit in your shit. Like, and that piece, or if I'm
Don't
hearing
be a poopy
excuses, like,
pants.
because you have to acknowledge, like, if somebody is not getting, like, and if somebody's not getting better, like, why are you not getting better? Like, how does these experiences, this trauma or whatever, like, what is it doing for you? Because sometimes there's a piece that keeps people in it because in some way it's serving something.
Well, and
So you
sometimes-
do have to acknowledge that and challenge that stuff sometimes.
We are seeing more and more, and it's hard to kind of have this conversation without going almost political in some ways, but
Yeah.
I'll try and stay out of that. But we also see it too in the way we're raised. Like if you're spoon fed everything as you're grown up, the first time you reach a challenge, it's I can't do it.
Tough times create hard men. Hard men create easy times. Easy times create weak men. I mean, we can say people, but it's an old quote.
Yeah.
But I mean, just like when I know when I was a kid, there was no you're gonna quit. You're gonna finish the soccer season, baseball season, whatever it was, whether I like that team or not. And then when it came to school, there's no you're gonna sit on the floor and keep crying, but you're gonna spell the damn word correctly over and over and over, or you're gonna figure out the math problem. There was no quit. There was no mom and dad are gonna come in and do it for me because I have to learn it. And you learn
Same
early
here.
on that the world is an unforgiving place. And not to make people mad, but it doesn't give a shit about you. Doesn't give a shit about me either. But you keep plugging away, and that's the way it is.
No tantrum you throw will solve anything.
You could be mad all you want. You know what? More power to you. Be mad. But get it done. Because the world does not care. I'm sorry. It just doesn't.
Greatest speech ever.
Well,
Rocky Balboa.
Yeah. It's not about how hard you hit.
It's about how hard you can get hit.
so I would
keep
hope that we
moving
could be a
forward.
little less cynical.
I'm not trying to be cynical, but that's breaking it all the way down to the base of it.
I'm going to challenge in your thought process here, and in your whole. I'm going to break. If you're not that cynical, are you truly preparing anybody that leaves your office for how cynical the world actually is?
Oh, everybody coming in my office is already jaded by the like effect by the world.
Yeah, true,
Nobody's
true.
coming in like Pollyanna, so I don't have to do that.
Say you didn't do first responders though.
Yeah.
It,
Oh, sorry,
Yeah.
you were staring at. I don't know. So wait, what's the question?
so say you didn't do first responder because I made
Uh-huh.
because we all come in realizing the world is shitty, so you don't have to convince us of it. But how do you take those almost I guess affluent individuals that have been spoon fed and toughen them up when they leave your office per se? If you weren't doing first responders,
Well, I mean, I guess the
Pass.
reality check.
Just say it. That's all you got to do.
Well, because it is complex, right? Like, I don't think, like, I think it would depend on the individual of, like, how they show up with something, right? But I think that so even, like, with a child, right? Like, when a child is reacting in a certain way, I'm always going to respond, though. Like, there's empathy is going to be a part of that, even if there's correction and behavior, and there's redirecting or whatever, like, but there can still be empathy. And that is a huge thing. Like we need, so regardless of whether you're a child or an adult, there's still some recognition and that diffuses, right? Like if you have a kid who, okay, so like my little nephew, his toy pinches him last night and he was tired already. So he's like crying and crying more than you would expect for what happened, right? My response is I knew like his volume was up higher than it necessarily quote unquote needed to be or should be, right? My response is going to be empathy and comfort and then encouragement to continue, right? But that's the base that I want to come from still is empathy and acknowledgement, but encouragement to keep going, encouragement to, and that builds resiliency, like relationship and healthy attachments and all of that stuff
Just
creates.
choke them out. It's easier.
And that
Then it's
that
quiet.
builds that, right? And but then there is an awareness of, right, we don't get everything that we want and life is difficult and things happen that are ugly and unfair and awful. That's going to be the question of human nature forever of why do bad things happen?
So it's life.
Right.
It's not perfect. It ain't pretty. But it's life. And it's a wonderful thing. I like disagreeing with people, trying to see it from the other side. That's one of the best things about life. Because if we all agreed on everything, it'd be pretty damn boring. If we were all walking around like robots.
Yeah.
But it's, unfortunately, it starts at a young age, and people just aren't taught that anymore. It's okay to lose. You can learn more from losing than you do from winning.
Yeah.
And it toughens you up. Like, when Ben was a kid, I didn't let him win. Every once in a while I would. But
Did you
no.
dunk on your child?
No, because I can't dunk. Fuck you. I'm short and vertically challenged when it comes to jumping. But I mean, that's the lesson you got to learn. You're not always going to hit a home run or the game winning, make the game winning basket or however you want to put it. You're not always going to get 100 on a test. Doesn't mean you failed. Just means you got to work a little harder. You got to put that work in to make things better.
3 out of 10.
3 out of 10 gets you the Hall of Fame. Unless you're Pete Rose.
Yeah, that's a good analogy. Yeah.
And I'm not saying you can't be empathetic. Empathy is a great thing. But at some point, you got to stop holding people's hands.
Yeah, and I think that's the thing. Like, empathy doesn't have to be coddling. And it doesn't have to, we don't want to make excuses or use stuff as an excuse or be sick to get something from it or whatever. And I think that's the thing, right? Because grit and resilience and that growth mindset is something that's appealing and that we want to encourage in our children and stuff, right? I can go through adversity. I don't have to become it. I don't have to shut down because of it. I don't have to quit because of it. That it can be a builder.
Mm-hmm.
So yeah, I get it. I'm going to tiptoe around stuff too. So
No, I couldn't do your job. I don't think the three of us could, because there is just that.
No, I mean, knifing at people.
I mean, we know how we were raised, and it was not easy.
No, didn't
but-
involve much coddling.
Nope.
That's for sure.
But I mean, you had everything you needed.
Yeah.
And you were taught the lessons that had to be learned.
Mm-hmm.
And your parents still loved you. They cared about you. They provided for you. But you had to earn your shit too. It wasn't just, hey, I need $20 to go to the movie. Well, what are you going to do for it? I'm not going to hand it to you because nothing's handed to you once you're an adult.
I see kids with credit cards now. What the actual fuck?
I mean,
right, but that's what you need to know, that they loved you. I think that's a bigger thing,
It
right?
is.
Earning,
I did the same thing with my son. I was
that's a big piece.
you're going to learn.
Yeah.
He's working. He has an apartment now. He's 19. He's almost 20. But, he still needs help.
I will
I'm
say,
not going to give you this money. You're going to mow the yard. You're going to pick up dog shit because I don't want to do it.
I will say for me though,
It's totally worth paying for.
it was a delayed response by about 20 to 25 years. Mm-hmm. Right? We see now, I need $20 for the movies. No. Throw a tantrum. Give them the $20. See, my mom loves me. It really didn't click for me till I was physiologically, in my brain, developing into an adult. And there were more situations I would look back and be like, oh.
Yeah. When you get older, it clicks.
It clicks.
Right.
So,
Yeah.
yes, I sacrificed on the front end the instant gratification and feeling of coddling or whatever you want to say for the bigger picture. And now I'm also a contributing member to society that doesn't sit down and cry when people clap too loud. So, I mean,
Yeah, I don't know. I think this is an issue. There's so many complexities to it, and you're talking about very much that the social media culture too, that
Instagram.
labels it.
No,
Yeah, and
let's
everybody
not go down
thinks
that
they're
road.
everybody thinks they're a clinician, and everybody because of stuff that comes through on social media that gives some tidbits about mental health or something, then
They're a
everybody thinks
clinician, they're a
or
lawyer,
they
they're a
diagnose
doctor.
themselves, and yeah,
I
and
read
so
it on WebMD.
and I hear, and I think what your experiences are too, you're going to naturally, because I get it, I will set if I have a day of really intense stuff or really, things going on with clients or I'm dealing with crisis or whatever, and then somebody calls me and is, complaining about, I don't know, our chairs. I remember that came up and I was super annoyed one day because I was like, I don't give a shit about the chairs right now. I'm talking about, I'm trying to keep somebody alive or get somebody help or whatever. And so I think when you're exposed to stuff, and just like you guys are, like, it's easy to go like, the other stuff seems stupid, right? And it's also easy to go home and go like, I don't care about the paint on the walls because I was just running calls like this all day, or dealing with crisis after crisis, or a bad call or whatever, or a night without sleep. And so I think, so we have to recognize that of what people are exposed to creates a different either sensitivity or desensitivity, to make up a word. But then also recognize what is relevant for somebody else and what is important to somebody else. But I think that we can minimize legitimate diagnoses by overexposing people to various symptoms, right? Like just even like PTSD, like not everybody gets PTSD, but because we talk about it constantly, there's so many people who will self-diagnose and go, I have PTSD, or assume that majority of people have PTSD, when that's statistically not the case, right? Is there PTS? Absolutely. But not everybody ends up with a diagnosable disorder. And so, and then I think sometimes there are parts of society or culture that feed the benefits that come from certain disorders or diagnoses too, that we have to be careful of. But
That sounds like a whole another show.
yeah.
Yeah.
We could argue and fight on that one.
But so be it. Like, I mean, like, this is one of the most getting to the bottom of our souls conversation that we've had in a while.
Yeah.
This might be one of those where we text each other and be like, did you sleep good last night? No.
So what is the summary today?
Oh, shit.
Don't suffer in silence. I think if I could stand with anything, though, that would be my thing, right? For you guys, regardless for anybody. And this is, I challenge my sister on this all the time, because I had read that story to her, because there was, sorry, she probably won't watch this anyway, but there was a time when she was a little girl. I don't mean it like that. She's so empathetic to my story that it's hard for her to hear things from me, right? Because then she gets upset by knowing if I experience pain.
You say she's gonna hate Jeremy more?
No, she loves Jeremy now.
Now.
But he was a little bit difficult to like at times.
Was?
When she was a little girl, there was like a wasp that was in her shirt and she was in school and it was stinging her repetitively. It's like much like that fox thing, right? And she wasn't saying anything. She was so quiet and not speaking up about it. And so it's like this wasp just continued to sting her while she was sitting in class and not saying anything. And that is something that we talk about all the time, because that is a part of her personality, to suffer in silence and to not say what's going on and to not ask for help. And so we talk about that all the time, and that's what this is. And that's part of what we have to acknowledge. Like, don't compare it. Don't pick up parts of this talk today and hear like, oh, I need to minimize it, or I'm making excuses. My trauma is not as bad as the next guy, so now I'm not going to say anything, right? Because that's what we have to stop doing. Like, get out of the comparison part, get out of the stigmatization part, get out of like the suffering and silence part, because that's what leads us to, and this is what you did and what so many people do, right? They just don't address or acknowledge or even sometimes aware of what's going on. But that's my thing. And to know, like, there's so much out there, and that's why, like, why we have these books down here, because other clinicians like Tanya Glenn in Texas and Shauna Springer and the Code 4 book of Tanya's, which I think I actually just gave out my last one, because I give that to a lot of clients because it just helps to understand how to stay resilient in the realm of public safety. And there's so much stuff out there, and it doesn't have to be like, it's not weakness to acknowledge that. But we have that mindset of that culture of like that stoicism, like it talks about, like that's somehow strength, to let the fox eat your gut and not say anything to anybody.
Yeah, that's counterintuitive. Because we'd ask for help for anything else.
Don't suffer in silence.
Don't suffer in silence. Yeah, I like it. All right. Do you have anything to add, James?
I loved today. I did.
Good.
Cool.
You good? You want to
Thank
add
you, guys.
anything?
I'm good.
Nelson even talked more than usual. So what I'm gathering is actually, we're just going to replace you
Shut up.
with Rachel. It'd be-
Perfect.
Yep.
I quit.
I think he
No.
was talking.
I'm not willing to
me.
get
Oh, I thought he
controversial.
was talking to me.
I have to step. I have to be so careful. I'm like, I'm not willing to be controversial.
Yeah,
I'm
we
gonna try to
noticed.
stay neutral. Yeah.
Yeah, he's not willing to be
It's awkward.
controversial either.
I mean,
Yeah.
it's interesting that like there's
Nope. I'm being good.
is truly breaking down something and making yourself uncomfortable controversial.
You know, with this subject,
With anything, somebody can find offense to anything.
yeah,
It's also-
somebody can find offense to anything. With this subject, it seems, depending on who you talk to, it could be controversial. But kind of the thought that I had is, you know, especially, and I'll speak just to the fire service. We're supposed to be like a family, right? We're supposed to be, for lack of a better term, our brother's keepers. You know, two guys go in the fire, 2 firefighters go in the fire, 2 firefighters come out. Right? This is no different. We have to stop treating the mental health issue that we have that is rampant in the fire service. We have to stop treating it with the stigma that it is and look at it. My perspective of looking at it is it's like an injury. It's no different than when you hurt your shoulder or hurt your knee or something like that. It is something that you can heal from if you take the right steps. Go do your PT. Go to an expert. We have to start looking at it that way instead of, oh, well, they're just not cut out for the job. You know, we're supposed to be a family. We need to start taking care of each other and start giving a shit. So that's my
Yeah.
perspective.
And I want to say, because I don't want to, I know I was dancing around where both of you were, but it's like, it's okay to put people, like, to talk to somebody, similar traumas to similar traumas. That's what I'm
Don't
trying
hit
to
your
say.
mic, your hands are getting.
I know
Be
they're getting a
careful.
little wonky. So, and I know Chris is hurting. So it's like, right, like we don't put, like, I'm not going to have a group of combat vets with, you know, a veteran who was just I don't want to say the word state or just, but who was deployed stateside, right? Like those things might look different. Those groups might look different. So a parent who loses a child to suicide, I'm not going to put them in a support group with somebody who just lost their, you know, parent to cancer, right? There are different things. There are different experiences, different traumas that sometimes need to be put together, which is okay. That's also okay to acknowledge that doesn't have to make something better or worse. They're different experiences and painful in different ways, and some have a greater intensity than others do, which is okay. But it doesn't have to minimize the other personal experience of somebody. But I know you're
All right.
hurting. Okay.
Well,
I agree. Sorry, I had to stand up.
Chris is in
No,
pain.
I'm
dude.
sorry.
Dude,
I'm dying over here.
I get it. I get it. Thanks for sticking it out.
oh,
So, and
ice bath.
yeah. Thanks everybody for stopping by. Like we end every episode. If you're struggling, reach out. There are resources out there. If you know somebody that's struggling, reach out to them. Let them know that you care. Let them know there are resources out there for them. Thanks for stopping by, and we'll see you next week.